Hi, welcome to the presentation on sedation and analgesia monitoring of the ICU patient. This presentation will give you a strong background on sedation and analgesia medications and how to monitor them in the ICU. The objectives of today's presentations are as follows. We're going to introduce opioids and sedatives in the ICU and speak about the different types. I'm going to talk about the stress response. We all have the stress response in life, and we certainly have it in the ICU, and it has a negative impact on you. We're going to list the different sedatives that are commonly used, which the major class happens to be benzodiazepines. We're going to speak about opioids. We're going to speak about the various types of opioids and also the synthetic opioids. We'll speak about Narcan, which is used to reverse opioids. And then finally, we're going to speak about weaning of patients from sedatives. And the importance of that is that we all try to get the patient off the ventilator. And if you don't wean down the sedatives to a proper level, you'll never get them off. So I hope you enjoy the presentation today. I just wanted to say a few words about the opioid crisis in America. 2018 data shows that every day 128 people in the United States die from overdosing on opioids. The misuse and addiction to opioids, including prescription painkillers, heroin, synthetic opioids such as fentanyl, is a serious national crisis that affects public health as well as the social and economic welfare. The Center of Disease Control and Prevention estimates that the total economic burden of prescription opioid misuse alone in the United States is over $79 billion a year. So how did this all happen? In the late 1990s, pharmaceutical companies reassured the medical community that patients would not become addicted to prescription opioid pain relievers, and healthcare providers began to prescribe them at greater rates. This subsequently led to the widespread diversion and misuse of these medications before it became clear that these medications were indeed addictive. In 2018, over 47,000 Americans died as a result of opioid overdoses, including prescription opioids, heroin, and illicitly manufactured fentanyl. These are all possibly killer opioids. The point what I want to say, though, that opioids are not that bad in the hospital. For example, they are the best choice to use when you are getting surgery or if you're in severe pain while you're in the hospital. Now, once you're discharged from the hospital, I don't believe opioids should be given to patients. So it's got a bum rap. And also there's a lot of people out there who are using this, recreationally, and that is a real problem in America. But in the hospital setting, I'm 100% behind the use of opioids to manage the pain. So why is sedation very important? When you think about it, when a patient is in the ICU, and especially if they're intubated, they need some kind of way of relieving the stress and anxiety that comes with intubation. This actually ensures patient comfort and safety, which is a universal goal of a healthcare practitioner. In a critically ill patient, pain and anxiety can contribute to a lot of negative physiologic responses, such as increased oxygen consumption, tachycardia, hypermetabolism, and immunosuppression. All of these things are very bad for the patient. Furthermore, unrelieved pain and anxiety can lead to severe agitation and possible removal of IV lines and self-extubation. All of these factors point to the fact that we need to get the proper amount of sedation on board to relieve anxiety and agitation and to ensure their comfort and safety. I wanted to get a couple of definitions out of the way, and those two definitions are anxiety and agitation. Both of them are reasons why we sedate patients. So there is a difference between the two words. For example, anxiety is a psychophysiologic response to the anticipation of real or imagined danger, where agitation is excitement accompanied by motor restlessness. So let me give you a couple examples. For example, We all get anxiety considering if we go down to the dentist to get a root canal, we may even lose some sleep the night before. We have this anticipation of pain, of danger, and we develop some kind of form of anxiety. That's a perfect example of anxiety. When you walk into a patient's room and they see you walk in with a blood gas kit in your hand, I could guarantee you they have some form of anxiety, being the fact they're going to be stuck. Now, where agitation is a little bit different. Agitation is anxiety. Well, let me just take a step back. Anxiety is all about the anticipation. It's a psycho type of thing where it's in your mind, where agitation is that you express your anxiety by movement. For example, if you're trying to jump out of the bed, that is agitation. If you pull your arm away from anyone trying to deliver a medication to you, that is agitation. If you try to rip out your ET tube, that is agitation. All of these are examples of agitation. So agitation tends to be characterized more by physical need to move, and where anxiety is about the worrying in the mind and the body, but they actually work both together, and sedation medications actually work on both of them. So let's talk about some indications for sedation. Basically, there's multiple reasons why sedation should be on board. When you're intubated and you have a tube down your throat, trust me, you're going to have a lot of level of anxiety and agitation because this is going to be uncomfortable. Also, patients who buck the ventilator. We all have had patients who are breathing asymmetrical with the ventilator, and as a result, they need some sedation on board. Some people, after being in an ICU for hours and hours and days, they get very restless. Also, in the ICU is very noisy. You got people talking, you hear IV pumps going, you see monitors going, you see different people walking in and out. This really frightens the crap out of you. Also, many patients fear medical procedures. Every time you walk in a room to get a blood gas, or if you're suctioning a patient, or if the nurse is gonna change a dressing on a wound, all of these things cause anxiety to the patient and agitation, and these are all great indications why we need to put some sedation on board. Before we go on, let's talk about the stress response. I'm sure we all know what the stress response is, as we all had stress in our life before. Some stress can be helpful. For example, you're walking down the street, you're crossing the road, and you see a car ripping up the street. You will automatically become alerted to this and jump out of the way of the car. This is a healthy response. Also, you can have stress because you can't pay your bills, or you're getting a divorce, and these kind of things could put stress on you, which is not too good. The stress response is also known as the fight or flight response because it evolved as a survival mechanism. This enables people to react quickly to life-threatening situations. It's an instantaneous release of hormones and also physiologic responses that help us get the threat out of our way. Unfortunately, the body can also react to these stresses that are not life-threatening, and this can sometimes do more harm to the body than good. When you're in the ICU, most patients end up getting some form of tissue hypoxia. Also, they could get bacteremia. These cause the same stress response in the body. And I want to tell you a little bit of how it actually works. It's initiated by the hypothalamus, and then the hypothalamus releases a hormone called CRF, which is released from the sensory nerves. The pituitary gland secretes a very important hormone called ACH. When ACH is produced, it further stimulates the production of two other hormones, one being cortisol and the other one being aldosterone. When cortisol is produced in excessive amounts, it suppresses the immune system, and it also suppresses the inflammatory response system of the body. This is produced because of the increased production of cytokines when cortisol excessively is produced. Aldosterone, which retains sodium in water, has been linked to problems with high blood pressure. So when aldosterone is produced in excessive quantities, it actually increases our blood pressure to negative effects on the body. Now we're going to talk about some sedative agents that are used in the ICU. Trust me, everyone needs some form of sedation in the ICU because you don't want to remember it. Let's talk about a very important class of drugs called benzodiazepines. Benzodiazepines, also called benzos, are a class of agents that work in the central nervous system and are used for a variety of medical conditions. They act on specific receptors in the brain called GABA receptors. Benzodiazepines attach to these receptors and make the nerves in the brain less sensitive to stimulation, which has a calming effect. There are various classes and types of benzos, and they all have various qualities to them. They are hypnotic, they are sedative, they are anxiolytic, they are anticonvulsant, they're also muscle relaxant, and they have amnesic properties. I want to tell you a little bit more about the hypnotic and sedative qualities. Hypnotic and sedative medications in general work by increasing the activity of GABA, which is a neurotransmitter in the brain. Increases in GABA activity in the brain produce drowsiness and facilitate and maintain sleep. Anticonvulsants are a diverse group of pharmacologic agents used in the treatment of epileptic seizures. Anticonvulsants are also increasingly being used for the treatment of bipolar disorder and borderline personality disorder. Since many seem to act as mood stabilizers, they are also used for neuropathic pain. When you talk about amnesic drugs are therapeutic for reducing bad memories of being in the ICU. You don't want people to remember all the negative aspects of being in an ICU, so this is why benzodiazepines work very well in this category. So let's start talking about some commonly used sedation medication in the ICU, and I'm sure you all know exactly which one they are. Atvan, Versed, Dipravan, and haloperidol are the class of drugs that are mostly used in the ICU to manage patients, and I will continue to speak more about them on further slides. I'm going to now cover two major drugs that are used in the ICU, which is Versed and Dipravan. Both of these agents are used for short-term use. That means less than 24 hours for the treatment of anxiety. They have many benefits and they produce sedation in a very short period of time, in less than 3 minutes. They also have a quick reversal time, which makes them very good for weaning a patient from mechanical ventilation. Versed causes relaxation and sleepiness. It is also used to cause a partial or complete loss of memory. It is commonly used to help a patient better tolerate a medical procedure. It is also used in the intensive care unit for patients who are on mechanical ventilation, as it's a great way of making the patient more compliant with the ventilator. Versed is typically used for sedation during procedures that do not require general anesthesia, but it does require a patient to remain calm and relaxed, such as a colonoscopy. Versed may also be used during surgery for sedation and also to keep the patient calm while on a ventilator. Versed has long-term administration accumulation in the body. So basically, if you use Versed, it accumulates in the body. Maintenance dosages are from 0.03 milligrams per kilogram per hour. It's basically titrated to effect over time, and you may have to use one or more bolus doses. Typically, rather than having a drip with Versed, they just give bolus shots with the patient to better manage their anxiety. Dipravan is a short-acting medication that results in decreased level of consciousness and a lack of memory for events. Uses include starting and maintenance dosaging for anesthesia, sedation for mechanically ventilated patients, and procedural sedation. One of the most common uses of intravenous Dipravan is to produce amnesia during minor surgical procedures. Ideally, Dipravan is to be used because of its intense amnesic effect. And Dipravan is basically given intravenously as a general anesthetic agent. It has sedative, hypnotic, anxiolytic, and antegrade amnesic properties. And the onset of action is really quick, typically 1 to 2 minutes, and then its effect is brief, like 10 to 15 minutes. Dipravan is really a good choice when you want to wean a patient off the ventilator because of the half-life being so short. The administration of Dipravan is typically done by continuous infusion. Long-term infusion results in accumulation in the fat cells of the body. That is one of the problems with Dipravan, that accumulates in the lipid stores in the cells. Basically, it's administered as an initial infusion rate of 0.5 milligrams per kilogram per hour, and then it's titrated upwardly. And it has a fast acting, typically less than 2 to 5 minutes, and then you could give increments every 5 to 10 minutes if needed. Weaning from Dipravan is very rapid, so you should expect that when you do stop Dipravan that you're going to see a reversal quite quickly. Before receiving this medication, please make sure the patient is not allergic to Dipravan or suffers from epilepsy or any other kind of seizure disorder. Another contraindication is high cholesterol triglycerides. Like I was telling you before, it stores in fat cells. Some adverse reactions from a cardiovascular point of view, it's been reported that some patients become bradycardic with it, and they also could either become hypotensive or hypertensive, and it could be either one. Sometimes some patients have an anaphylactic shock if they are allergic to it. Priapism, apnea, respiratory acidosis are all types of negative effects of Dipravan, so you should keep a watch out for those. Patients in the intensive care unit require sedation for many reasons. When long-term ICU stays are anticipated, Atvan is a better choice. Long-term infusion of Versed has been shown to have a negative effect on hepatic and renal function. Therefore, Atvan is a much better choice. Versed also is more expensive than Atvan. The cost of Atvan is 10 times cheaper than that of Versed. When comparing Atvan to Versed, Atvan has a longer acting process, less hypotension, has antegrade amnesia, and a lower cost as mentioned before. It also produces a more rapid awakening. Atvan is mostly administered through intermittent bolus injections, but really everyone uses it as a continuous infusion. The dosage is typically 0.044 milligrams per kilograms, and that's given every 2 to 4 hours. You may need to use a leading dose with this because the onset of action of Atvan is a little bit longer than Versed. Sometimes you might want to give a bolus of Versed before you do the Atvan because you'll have a better effect that way. Let's talk about Haldol and its treatment for delirium. Delirium is characterized by impaired cognition and a reduced ability to appropriately respond to external stimuli and in disorganized thinking, such as rambling, incoherent speech, and irrelevant speech. As noted, there's a decreased level of consciousness with altered sensory perception and disorientation. In a critically ill patient, it may develop secondary to different predisposing causes. Although it can be transient and reversible, its occurrence in the ICU may be associated with long-term cognitive dysfunction. This condition is often underrecognized and leads to inappropriate treatment. For appropriate management of delirium, early identification of risk factors and assessments are some of the key factors needed to get a handle on this. Multidisciplinary collaboration and standardized care can enhance the recognition of delirium. The use of physical restraints may be necessary to prevent harm to these patients, especially those who are mechanically ventilated, but you need to use some good judgment with ethical considerations in regard to that. The management of delirium in the ICU has led to the use of Haldol, which has been shown to be very effective in the management of these patients. I am sure you have heard the term ICU psychosis. And basically, ICU psychosis is a disorder in which the patients in the intensive care unit experience anxiety, become paranoid, hear voices, and see things that are not there. And basically, they become very disoriented with time and place, and they become very agitated and even violent. Sometimes this could be a side effect of the use of opioids or benzodiazepines to manage the symptoms. People think that the best way to do is calm them down, but they are actually suffering from delirium, so the use of benzos and opioids is really not the right choice. Basically, you can have a paradoxical worsening of symptoms and the patient become quite violent. So you really need to manage them appropriately with the proper medication, which really should be Haldol. Haldol has proven to be quite effective for delirium in the ICU. Clinical effects of Haldol can be noticed within 30 to 60 minutes and may last up to 4 to 8 hours. A typical dosage of Haldol is anywhere from 2 to 10 milligrams, and it's administered intravenously, and this could be repeated every 2 to 4 hours. You really want to manage the patient appropriately in the ICU, and given the proper medication, especially for the case of delirium, Haldol is the winner. I want to tell you about the last sedation type of medication, which is called Precedex. As we all know, the process of weaning the patient from mechanical ventilation is central to what we do. It is definitely a difficult task and is a very complex task. Attention should be paid to wean the patient off the ventilator as soon as possible, because staying on a ventilator increases ICU stay, increases the mortality of the patient, and increases cost. A majority of the patients who are on ventilatory support receive some form of sedation and analgesic medication. They need this to actually make the patient more comfortable, reduce pain, and all of these things are part of the normal care in the patient in the ICU. The two major classes of medications used in the ICU are either benzodiazepines or opioids. Both of those can prolong the stay of a patient on a ventilator. Both of them have their side effects. Atvan, which is given intermittently via IV infusion, is recommended for guidelines for patients who are going to be on mechanical ventilation for a long time, whereas Versed is recommended for short-term use. So if you have a patient on a ventilator less than 48 hours, Versed is your go-to. Also, Versed causes systemic failure. Basically, it reduces systemic vascular resistance, and what that means is then the patient ends up being hypertensive. It also produces some respiratory depression and apnea along with opioids. So if you give opioids and Versed together, or Atvan and opioids, sometimes you can have suppressed ventilatory support. To eliminate the prolonged critical stay of patients in the ICU and on ventilator, Precedex is a newer sedative, and it also an analgesic. Basically, it produces less hemodynamic issues. It also appears the patient does not go apneic. Its sedative properties are unique, that it only produces mild cognitive impairment, allowing easy communication between the healthcare provider and the patient. It does not suppress the respiratory cycle, and it's a great tool to use when you're weaning a patient from mechanical ventilation. Okay, everybody, I want to test your clinical skills. You see the woman in the picture? Is she suffering from pain or anxiety? What do you think it is? How can you determine what's going on with this patient? It takes a little practice. Now let's turn our attention to the concept of pain management. Most, if not all, patients in the ICU experience various levels of pain. As a general rule, you need to manage pain before you manage sedation. Examples of pain could be pulmonary dysfunction, cardiac dysfunction, trauma, surgery, cancer. Even being intubated can cause various levels of pain. The goal of the clinician in the ICU is to manage the pain and to manage the pain correctly. It's been demonstrated that pain management in the ICU has been inadequate. Many patients have pain and we don't recognize pain, and actually we end up giving them sedation medication, which actually does very little for pain. There are many reasons why pain management is not done correctly in the ICU. First of all, if someone's intubated, they cannot verbalize the pain they're in. They got a tube down their throat. They can't say a word. So patient providers need to really understand cues, what goes on, who's in pain, and how to recognize pain. The desired goal of the clinician is to relieve the pain and suffering of the patient without giving them too much sedation and pain management that they can't come off the mechanical ventilation. The consequences of pain are many. There are a lot of physiologic responses to pain, such as tachycardia, increased myocardial oxygen consumption. Many of these patients are immunosuppressed, and they could be in a persistent catabolic type of state. All of these things really don't work very well for the patient. When we talk about analgesic medications, it's very important that we understand levels of pain, and there are various tools used. The most common tool used that I'm sure you have seen, which is on the screen, is called the Wong-Baker Faces Pain Scale. This is a scale that sort of determines, based on how they feel, what kind of pain level they have. Another example is called the Flack Scale, and another one could be called the Cry Scale. And finally, there's what they call the McGill Pain Scale. There are many other pain scales out there, but I'm sure you're familiar with this one. And nursing uses different scales at different hospitals. And remember, the goal of control is to control the pain before you control the sedation. When we're talking about pain relief, opioids are the cornerstone of analgesia in a critical ill patient. Opioid analgesics such as morphine, fentanyl, and hydromorphine are the most common intravenous opioids used in the ICU to manage pain. Opioids are effective and offer a wide therapeutic index to most patients. Most frequently, opioids are used in the ICU to manage the pain. They are effective, they're affordable, they also give you an euphoric effect, and they are the go-to drugs. Some of the problems with opioids is that they release histamine, which causes hypotension. It causes a drop in your blood pressure. I wanted to go a little bit more detail about morphine. The normal half-life of morphine is anywhere from 1.5 to 2 hours, but each patient's response to morphine may differ. And the reason for this difference is the protein binding qualities of each person. Some drugs will act more exaggerated on some patients, where some patients may feel a less response. Another concern is histamine release. When histamine is released in the body, it creates a vasodilating effect, which causes hypotension. And another concern is respiratory depression. Too much morphine will suppress the respiratory cycle and make the patient apneic. So you really need to be careful about these things. I wanted to talk a little bit more about morphine administration and dosing. Basically, morphine is administered intravenously. A normal starting dose is 0.05 milligrams per kilogram, and it's administered over 5 to 15 minutes. Most adults require a dosing of 4 to 6 milligrams per hour, and redosing will be required based upon how the response to pain is going to be, and that can be done every 1 to 2 hours with continuous infusion therapy. Here is a listing of some morphine contraindications. Number 1, extremes of both ages. Basically, if someone's too old or too young, probably under the age of 3, morphine would not be a good choice. Another is bronchial asthma, respiratory insufficiency, especially with patients with emphysema, head injury, someone who's in shock, who has hypotension, because obviously morphine can make him more hypotensive, undiagnosed acute abdomen, and the reason for that is because it could obscure the real diagnosis of what's going on, BHP, renal failure, liver disease, hypothyroidism, and sometimes for patients who have a history of drug abuse. All of these may be contraindications for the use of morphine. Fentanyl is a synthetic opioid with a rapid onset, typically 5 to 15 minutes, and it has a short duration of action, typically 30 to 60 minutes. It is easily titratable as a continuous infusion. In general, a loading dose of 25 to 100 mics of fentanyl are given every 5 to 10 minutes until the pain is controlled. The problem with fentanyl is that significant drug accumulation and prolonged half-life can occur with some patients, especially patients who are obese, where it would store in the fat cells. However, there is less histamine release than morphine, and it doesn't go renal elimination, two good factors. It is a preferred opioid analgesic with hemodynamically unstable patients and those with renal insufficiency. It is good for patients who also have morphine allergy. As I mentioned before, fentanyl is a synthetic opioid, but it also offers some greater potency. The benefits of fentanyl is that it has a faster onset of action, so it can relieve pain much faster than morphine. It does not cause histamine release, and you realize that histamine release actually makes you hypotensive. It has a relatively short half-life of 30 to 60 minutes, but some of the problems with fentanyl is that it has a prolonged accumulation in fat cells in the body. So what that means is if you are overweight and you are given a continuous infusion of fentanyl, it could store in your fat cells, so when you wean off the fentanyl or they shut it off, you could still be under the effects of fentanyl because of the fat cell accumulation, and it may take a long time for you to come out of it. Fentanyl, unlike morphine, has very little euphoric effects. It actually has no active metabolites. It's definitely good for patients with morphine allergy. It should be administered by continuous infusion at a rate of 1 to 2 micrograms per kilogram per hour. And you need to have one or more loading doses of 1 to 2 micrograms per kilogram when therapy is initiated. These are some of the guidelines you could use with fentanyl. I thought I'd tell you a little bit about some cases of patients showing respiratory depression on fentanyl. The reasons why our patients have shown this depression. And here are a couple of good reasons. As I told you before, some patients who are overweight store fat. Hydromorphine is a semi-synthetic opioid, and it's derived from morphine. It is 6.5 times more potent than morphine, and that sometimes can lead to dosing errors and overdosing. It has a relatively long half-life, anywhere from 2 to 3 hours, and it may accumulate in the body. It also contains neurotoxic metabolites that can really cause some renal damage if you take too much. Hydromorphine can be used to provide analgesia for patients who do not respond to normal opioid doses. it is definitely an acceptable alternative to morphine. It has less euphoria than morphine, and the dosages should be titrated at 0.0, 0.5 milligrams, and typically you might have to give a new dose every 1 to 2 hours. The last opioid I like to talk about is demerol. Demerol is just like morphine. It actually produces less smooth muscle spasms, less constipation, and it has a slightly more rapid action than morphine. The duration of demerol is a little bit shorter, and some of the contraindications, if you are on an MAO inhibitor, really this is not the right choice for you. Dosages start anywhere from 50 milligrams to 150 milligrams, and it can be given every 3 to 4 hours. It's commonly used to relieve pain, and it can also be used as a sedative. A conversation of opioids would not be complete unless I mention Narcan. Narcan is used to completely or partially reverse the effects of narcotics. So if someone is overdosing on narcotics, this is the go-to drug. It is called a narcotic antagonist. It basically blocks the receptor sites, the opioid receptor sites, and reverses the toxic effects. So if someone is on opioids and they have respiratory suppression, they're not breathing very well, this is the go-to medication. It is sold over the counter, and it's actually saved thousands of lives here across America for those who abuse opioids at home. You may be asking yourself why I have this slide in here. And to tell you the truth, the whole purpose of this presentation was about weaning patients from mechanical ventilation. When we created a weaning protocol at our hospital, part of the strategy was to assess the patient each day, and to do this, the patient had to be weaned off medication. So we would wean the sedatives at 6 a.m., and then by 7 o'clock, 7:30 in the morning, we'd be assessing the patients. And some of those patients didn't come off the effects of the sedation medication, so they failed the weaning protocol, and I got very concerned about that. So what we decided to do was do some education for our respiratory staff on the use of analgesics and sedative medications and tie that into the RASS score. And what that means is that our weaning protocol was geared toward weaning the sedative medications off the patients in the morning, and then to do an assessment if they're ready to come off the ventilator or be weaned that day based upon how they responded in the RASS score. The key is great communication between the staff members. It's also the timeliness to weaning is very important. For example, why would you try to wean a patient from mechanical ventilation when the sedation is on board and they're not responding appropriately? The RASS score is a great tool to determine when they are ready to wean, and my next slide is going to be talking about the details of the RASS score. Let's now turn our attention to sedation scales. The most common sedation scale we used at our hospital is called the RASS score. Basically, sedative and analgesic medications are administered to many patients who are in the critical care unit. The consequences of inadequate sedation and analgesia can be substantial, including self-extubations, removal of vascular catheters, aggressive behavior, and also poor patient ventilator synchrony. The therapeutic sedation has inherent risks too, particularly with excessive and prolonged administration. The increasing recognition that the use of sedative medications can have a substantial impact on the duration of ICU stay and complication has made way for creating sedation scales. Reliable sedation tools can enhance communication amongst caregivers, improve consistency in drug administration, be used in sedation protocols, and improve the precision of medication titration as patient needs over time. The most common scale we used at our hospital is called the Richmond Agitation Sedation Scale. And as you can see, if you are a +4, basically you're jumping out of the bed and you're ready to kill somebody. And if you're a -5, you're completely zonked out and you're not going to respond to anything. So when you sedate somebody, you want to keep them probably to a -3. So you give them enough sedation on board that they're a -3. And another way of looking at it is if you're trying to wean a patient, you would wean them when the best score they could possibly be is a 0. But we used to try to wean patients from the ventilator when they were anywhere from a -1 to a +1. So we would reverse the medications at 6 a.m. and then they would start waking up and they'd be alert and awake, and we just do some weaning protocols from them at that point. If we try to decrease the sedation and they were still a -3 or a -2, we didn't bother weaning them at that time. We waited till they were, like I said before, a -1 to a +1, with 0 being the best score. So the Richmond Agitation Sedation Scale is a great way to determine, when you titrate sedation medications off the patient, when is the best time to wean them from mechanical ventilation. In summary, I hope you enjoyed today's presentation. I want you to know more about the sedatives and analgesics that are commonly used in the ICU. And I like to say that opioids are the proper medication to use in the ICU. If you are in pain or if you're getting surgery, those are your go-to drugs. And as I said earlier in this presentation, I don't believe opioids should be given to patients who are discharged at home. Another important factor of this presentation was the factor of weaning patients from the ventilator. You really need to know that the patient is completely weaned off sedation before you attempt to wean them from the ventilator. And the use of the RASS score is a great tool to doing that. And also, you should recognize the signs of opioid overdoses. This way you could intervene at the right time. There are many great references on understanding sedation and analgesic medications in the ICU, and I listed 3 here that I feel that would be very helpful to you. Each of them are comprehensive in the fact that they make it a very good guide for clinicians like yourself to manage patients in the ICU. And I hope you really enjoyed this presentation again.